this talk is around AI in healthcare. I think lots of people here have particular interest in that, but it is coming for all of us. It's not hypothetical anymore. It is here. It is going to influence our practice, if not already. We have to be very careful about that, how that happens. But I think that all of you are in a unique position to influence that. You know, you are going to be the generation who's not only post-COVID, but are growing up with this technology. You are digital natives. You've probably been programming since you could build blocks, right? They have Python you can program with blocks now, right? It sounds like great fun. I've kind of wanted to play with it. But there's an approach that we have to take as clinicians. Sorry, this talk is mainly around clinicians.
I used to work in the clinical cardiology department. So
oh, that's great. Where we are coming to this with a particular lens, and we have a responsibility in that regard. Which brings us to knowing the present, foretelling the future, to do good and to not do harm. It's prescient about artificial intelligence in healthcare, and it sounds a bit familiar. It sounds like a quote I've maybe heard somewhere before. Do no harm. Who said that? It sounds kind of like Hippocrates. It is. So everyone's probably heard, you know, the Hippocratic Oath, first do no harm. Does anyone actually know where it came from? So Hippocrates wrote a few things. He was a very prolific author. I'm not sure how many citations he had on Scopus, but the first do no harm is actually only one translation of what he wrote. It's been translated multiple ways. And in this instance, it doesn't actually appear there, and it's not actually the same document as other parts that are incorporated into modern Hippocratic oaths. And this highlights that small changes in language can influence our interpretation. We can be told something many times, first do no harm. That's part of the Hippocratic Oath, right? That's what Hippocrates said, right? And at some point, you just believe it. It's fact. It's the illusory truth effect. You know, like bats are blind. Bats aren't blind. And the vision's probably not great, but they're not blind. If you hear something enough times, it becomes truth. AI can very much play into this. So there's a great article that I'd recommend reading just from a kind of human medicine perspective about the different interpretations. It was written by a group at Harvard, and that's where I'll be going in a couple of months, but I will still be active in this journal club because I think it is important. I think we need to approach everything in medicine with a questioning approach, because if you are taking something as truth, you want to make sure there is a good evidence base behind it, especially if you're treating another human based on that truth. Now, the structure for today's talk is based around the statement. So first we're going to talk about doing no harm, even though that's only one translation. Then we're going to talk about how hopefully AI can help. And then at the end, we'll finish early so you can talk to other people here about how you can get involved. So first off, AI can harm healthcare. Now this is a talk that I've actually studiously avoided giving. I always thought that, you know, dystopian AI in healthcare was too easy, right? You know, everyone's thinking of the Terminator, everyone's thinking of Skynet, and it's taken all of our jobs. It's too easy, right? But I think that whilst there are some very apparent risks, there are some less apparent risks, and they're the ones that worry me more. So in terms of the risks that you see coming, I think we all know about confidentiality. Hopefully everyone knows here that you shouldn't be putting confidential things into, you know, various chatbots that then send them to some sort of server on an offshore site, and it's, you know, not protected, and people get reported to AHPRA for that. I think most of us are aware of the risk of bias in these algorithms. What data has it been trained on? What stereotypes is it perpetuating? We've probably all heard about hallucinations. Personally, from a neurology standpoint, I think they should be confabulations, but we're going to stick with calling them hallucinations. This is a project that is ongoing, looking at ECG production. This is actually trying to get a good-looking ECG. Didn't quite make it. Public perceptions, I think, is getting a little bit less obvious. Now, this is an article that was actually as a result of an algorithm that I made. This is not what I had planned when I wrote a carefully nuanced, qualified argument that was writing down all of the limitations of the algorithm. You get 2 words. Now, this was a positive article. which is great. I think it's really important. I think it's positive research. But you could imagine that very easily that title could be not positive, right? You write your carefully nuanced scientific piece, but how's the public going to see it? They might only see those two words. The legalities is a bit of an uncertain area at the moment. Now, I know there's some people doing work on this in the room. Law is interesting. I don't know a huge amount about the law. I plan on keeping it that way from a medical standpoint as much as possible. But I know about the concept of precedent in case law. When you have new technologies, inherently there is limited precedent. Inherently there are areas that are untested. Disinformation, we probably all heard about from a political standpoint, very real from a medical standpoint. This is a really interesting piece of research where I'm sure you can all imagine you've got your large language models, you can all use them, you've all got ChatGPT. Have you tried to use it to generate disinformation? Turns out you can. There's meant to be safeguards in place, but it's actually not that hard to jailbreak. And then when you report it to the companies, hey, did you know you could jailbreak this really easily and generate a lot of disinformation? It didn't get fixed. That's why I think the article got published in a reasonably high impact journal. Getting more nuanced again, you can make an accurate algorithm. Say you're predicting mortality. Mortality is important. I want to predict mortality. Maybe I don't want to predict mortality. Do you want to predict mortality? Do you want to know? No. But what if it's something that I can't do anything about? So, sun was going to rise. I told you so. Is that actionable information? Is it something that I already knew? If you make an algorithm that's predicting something that's blindingly obvious to every clinician, or is entirely unmodifiable, is that useful research? Is that a useful use of resources? A lot of research in COVID, I think, demonstrated algorithms that predicted outcomes that weren't entirely useful. So now the risk that I think quite a few people haven't seen coming, and Tiger's looking a little bit anxious there and not really excited. So we work in healthcare systems. Depending on how long you've been in a healthcare system, you will have different insights into this. When you work between hospitals, between health networks, between states, between countries, you will get additional insights into this. It is possible to make an algorithm and scientifically show that it provides a benefit in one location and then transfer that to another location and have no benefit. For example, a triage process. If you're triaging radiology scans at one center and it provides a benefit because they have a lot of scans sitting there unread, and you take that to another center where actually the waitlist really isn't that long at all. They've got great radiology service, there's no need for a triaging system. You could have a very expensive algorithm that's providing no benefit whatsoever. That's leaving aside the potential for bias. Unexpected costs is one that I worry about. Some of these keep me up at night. So say, you're a PGY3 RMO, life's going well, you've got enough money to buy a nice car for yourself, you look at how much they cost, and you get yourself a nice car. Great. Say it's a PGY3 RMO by like a Ford, I don't know. Maybe you've been around a bit longer, you've got yourself a Mercedes. Great. Now, that cost a fair bit up front, but it's a nice car, right? It's German, it's going to hang around for a while, it's good quality. And then you realize, actually the first service is due. I've got to take it back to the same place. They charge quite a bit for services. I need some new parts, but I can only get them here? And you charge even more for that. All right, and now I need my next service even sooner because there was a problem. And you mean for the rest of time that I have this car, I have to keep coming back to the same place to get it serviced? Oh man, these costs are starting to add up. It's not just the upfront cost of the algorithms, it is also the maintenance cost. Who is maintaining these algorithms? We need systems in place for this. Unintended consequences come in many forms. The one that I think we need to be particularly cognizant of as clinicians is the adage, this is going to give us more time with patients. It'd be very easy for more time with patients to become more patients per unit time. If you have a healthcare system that's already operating beyond its capacity and you have something that can make you see patients faster, are you going to get to spend that extra time with each patient to talk to them about a nuanced delicate, life-altering issue, or are you going to be expected to see more people? We need to think about how our systems are going to respond to increased capacity. This is going to be integrated into our workflows. But what happens when the workflows stop? Who will take on that extra work? If we have an algorithm that is producing, say, an interim discharge summary that you can then edit, sounds great. We're trying to do work in this area. What happens if the algorithm stops working? Do we now not have sufficient interns to do the whole task? Similarly, triage services, similarly, reporting services, even administrative services. We will build systems that are dependent on these algorithms. We need to think about that. I don't have all the answers. This is just something we need to think about. These algorithms can produce a lot of text. There's already a concept of note bloat in hospitals where there's a Met call, you're the Met lead, you arrive at this patient, you've never met them before, say, what's their issues, why are they in hospital? And the person sitting at the computer is scrolling and scrolling. So what are you doing? Why are you still scrolling? I'm still on the ward round note. They've been copying forward this thing that goes for longer and longer and longer. Dictation software will capture even more information. Large language models mean we can very quickly and cheaply generate a lot of information. We need to think about the cost of the people trying to read that. Their time is valuable, their attention is valuable. It needs to be distributed effectively. Not just in clinical medicine, but in science. This can generate a lot of text. Can generate a lot of grant applications, can generate a lot of manuscripts. Who's going to read all of them? That time is valuable. This is where we get a little bit more conceptual, and I think interesting. Who here's written a systematic review? You can put your hands up surreptitiously, in case you're scarred. So it's a difficult process. It's time consuming. It's a little bit arduous. It's valuable though. You learn a lot. You learn a lot, don't you, JS? Yeah. So what if an algorithm could do it for you? That'd be wonderful, right? We're going to have algorithms running all of our systematic reviews. They're going to synthesize all of our medical evidence. But you're a specialist now. You're a specialist, and a patient's come to you saying, hey, I typed this into an algorithm. It said I should do this. Specialist says, yeah, I just read a systematic review. It was written by the same algorithm. Checks out. Seems about right. If you aren't interpreting the evidence yourself, if you're seeing everything through an algorithmic lens, we've already heard about filter bubbles in the setting of politics, right? We know that that is a potentially fraught area. If we have all of our evidence coming through the lens of artificial intelligence, could that have implications for our ability to practice evidence-based medicine? And then captive markets. Has anyone heard the word enshittification? So,
again slowly. And then emphasize the middle bit.
Enshittification. It was like the 2023 word of the year. I bet you all know who was like the Times Person of the Year last year, right? Taylor Swift, right? Everyone knows that. But no one knows the word of the year. Maybe only I know that. It's all right. Taylor Swift has advantages and disadvantages. Different talk. So enshittification describes platform decay. So classic examples that are discussed are Facebook and Uber. So these companies, they have loss-leading activities. So it goes into a country, they operate at a loss. It means that they get to replace, say, all of the taxi services. They own the business, they get a captive market, there's no competition. Then it makes sense from a financial standpoint for these commercial companies to increase their revenue as much as possible over time, to the detriment of the service at some extent. An example would be YouTube. For YouTube's revenue-raising model, does it not make sense for them to show you as many ads as humanly possible that you can tolerate before showing you the content? It makes sense, right? But did they do that at the start? Have you got kind of the longevity to remember what YouTube was like when there were fewer ads? Yeah. What about Facebook algorithm? That is well described with these platforms. It is not being discussed with AI in healthcare. But you could similarly end up with a captive market in healthcare where your system is dependent, your healthcare system, your patients, your population is dependent on an AI system. It makes sense from a capitalist standpoint for that company to maximize profits over time. You need to make sure that there is competition, and need to make sure that there is interoperability, so that, say you've developed a pipeline here, can I change that pipeline to a different company, a competitor, a different vendor, so that we are not trapped? This is a contemporary issue in South Australia. But then, ultimately, I'm glad some people get the references. I thought they'd be too old for you. We are clinicians. We practice evidence-based medicine. We need evidence for everything we do. If you had a friend who came to you and said, hey, I've made this new drug. It's great. I got my own setup at home. I read about it online. I cooked it up. Do you want to give it to your patient? No, what are you doing? This needs to go through the TGA, needs to go through the Drug and Therapeutics Committee. There's multiple steps involved. For AI, you can very much have people who are making the algorithm in their bathtub and then bringing it to healthcare. These people mean well, but there are steps involved, and we need evidence for what we do. So that's enough about the depressing content. So what are we doing? That's enough of the things to worry about. What can we do? This is work that we're involved with at the moment. It's work we're excited about. So a framework around this is, unless AI is making autonomous decisions, often it's providing information to clinicians, right? So the question is, which information are you giving them? How is that being communicated, and to whom is it being communicated? It could be multiple people, could be multiple modalities. It needs to be communicated well. So a lot of people have a lot of dashboards, and a lot of people don't have time to look at all their dashboards. That be fair, Thompson? It's too many dashboards already? Yeah. Sage nod. I agree. This needs to be curated for clinicians. So at the moment, this one is actually not necessarily AI. This is just informatics and communication. But can we deliver the information to clinicians in their hands at the right time so that they can use it? This is a project that we're using looking at bowel management and glycemic management. It's already shown improvements. That wasn't even AI. What about when you combine AI with it? We'll come to that. AI can be useful for auditing. So audits are important for medicine. You need to check what you're doing. Similar to a systematic review in a lot of ways. It takes a while. So large language models work quite well with this. So one that we're doing right now is using large language models to look at the prescription of intravenous immunoglobulin. Now, IVIg, intravenous immunoglobulin, use it to treat a number of chronic autoimmune neurological conditions, right? Like CIDP, multifocal motor neuropathy, sometimes myasthenia gravis. It's expensive. It costs more per weight than gold. It's about $59 a gram, roughly. Depends where you buy it. It's not always weaned as well as it could be. There's a variety of reasons for that. You can use AI. We've used AI. We're currently using AI to see if you can spot people where it should be weaned. Now, giving people blood products, it's a scarce resource. There's donors. It's not just the cost. It also has side effects. People get vasomotor reactions. It's increasing their viscosity. It predisposes them to deep vein thromboses and venous thromboembolism. This is AI that we are using in South Australia right now, but we have multiple steps to go through. This is not ready for practice. This needs to be tested in multiple settings, and then it needs to be implemented and have the outcomes evaluated. And we plan to do all of that. I'll get you the manuscript this weekend. Screening is another possibility. Now, all of this is only possible because of a team. This work is being led by Sean Evans, who is a cardiologist. He is doing some fascinating work using AI to interpret ECGs. Now, we're talking about, do you want your mortality predicted? Do you want to know how old your heart is? So Sean is doing some really interesting work, again as part of a team, looking at, can you tell how old someone's heart is from their ECG? And the answer is yes. I'm not sure if I want an ECG now. Maybe I'll go for a run first, hey Lewis? Now, antibiotic allergies, people probably heard me talk about this before. Penicillin's a life-saving drug, right? If you have sepsis, you want to get antibiotics into someone, you want to get in quickly. You don't want to have to think about penicillin allergies. We've got AI that's gone through multiple steps. The algorithm was derived. It was then validated in different cohorts. It was then implemented and showed to provide a clinically meaningful benefit for patients in an evidence-based manner. And now we're implementing it again in other ways. So this work's being led by Mel Jiang, who's an RMO who's now at Flinders, who is looking at the proactive delabeling of penicillin allergies guided by artificial intelligence. What about neurology? We always need more neurology, right? I'm sorry so much of this is neurology, but it's good, right, Justin? Now, epilepsy is a big topic. Up to a third of patients might be medically refractory. Some of them might be cured, or at least seizure-free, with epilepsy surgery. We know that we don't refer people as much as we should. There's a lot of reasons around that. In South Australia, we are currently sending them to Victoria. We can use algorithms to find people who might be candidates for epilepsy surgery and provide these people with potentially lifelong benefit. It's hard to go through all of the notes of everyone with epilepsy in the state. This is a use for artificial intelligence that I think is necessary in an ongoing manner. And this one's also running. It'll probably be another week or so after this weekend. And then the Adelaide Score. Now, the Adelaide Score was the one that made that news article, championed by Joshua Kavor, who's now working in Victoria. This is looking at discharge prediction. It is also part of a program that's being run by Toby Gilbert called SWIFT. Now, I can't remember what it all stands for, but Supportive Weekend Interprofessional Flow Team. Dr. Gilbert worked very hard to make it spell SWIFT. So when we used AI and put AI in front of it to make it work more efficiently, I only had one choice. You had to make it spell tailored Swift, right? It took me a few tries to make it spell tailored Swift. It was worth it. We've shown that using artificial intelligence in conjunction with a specialist weekend discharge team, we can increase weekend discharges. Hospitals get full-on weekends because people aren't going home. We all know about ramping. This work is happening now, and it is currently having an impact in South Australian healthcare. Again, this went through multiple steps. It was derived. It was validated in different cohorts, and now it is being implemented and having that assessed, looking at patient-oriented outcomes and adverse effects. Like, you don't want to just discharge everyone and have them come right back. You got to look at readmissions and all of that as well. And it's getting some attention. So this was in the news maybe a week or two ago. This is an article about ramping in South Australia, and the Health Minister, Chris Picton, came up to the Lyell McEwin and spoke positively about some of the work that's going on at the Lyell McEwin, including the use of artificial intelligence to increase weekend discharges. So this is not hypothetical. This is here now. This is work that you can all be involved in. And I think that I've kept to time, hopefully. I'm going to wrap up the talk, but I'd be interested in your thoughts, because right now, there are ways that medical students and trainees can become involved in this research even without accessing patient data. You look at that article that was published on disinformation in the BMJ. That was something any of you could have done. These are publicly available algorithms. How to jailbreak them is publicly available, for better or for worse, probably for worse. What about other ways that these algorithms might be used wrong? Currently, they're publicly available. Patients can use them. What about if a patient says, hey, what's the role of arthroscopy for knee osteoarthritis? Now, it's a bit of a trick question, possibly. You don't necessarily need an arthroscopy for knee osteoarthritis. It's quite often an unnecessary procedure. There's guidelines around that. So there's the Choosing Wisely guidelines, and they very explicitly say when you should not do this. If you put that into ChatGPT right now, it's going to tell you all the reasons to do it. Because it depends on how you write into it. And I don't think we know how patients are writing into it. I don't think we know the information they're getting out of it. And I think that the Choosing Wisely guidelines are a great place to start. I think this could be evaluated in every specialty there, because when evidence is contentious and when questions are framed in a well-meaning but perhaps not careful manner, they can provide results that are misleading.